So our group is Bystander CPR, and our idea is bystander CPR training for minorities and members who live in lower socioeconomic areas. And our problem statement is non-medical laypersons need bystander CPR training because it will improve their knowledge and skills for emergency preparedness. By focusing especially on lower socioeconomic areas for our project, we can increase the number of citizens who are trained in CPR training and increase survival rates of out-of-hospital cardiac arrest in the community.
And so we just conducted some evidence in order to support our project and see how beneficial bystander CPR can be in the community. So we looked at 3 articles. The first article is titled "The Effect of Bystander CPR on Survival of Out-of-Hospital Cardiac Arrest Victims." And this article discusses the outcomes of cardiac arrest patients who received bystander CPR versus those who did not receive bystander CPR. The outcomes show the results of patients who survived to the hospital and upon discharge between the 2 groups. The article also discusses factors relating to patient survival. This article supports our challenge because it gives us data and results to prove to the high schoolers that bystander CPR does save lives. The article also discusses factors to patient survival, such as timing of CPR before EMS survival, age of patient, and locations. Understanding these factors can help us create strategies to help treat cardiac arrest patients outside of the hospital in our community. The second article was titled "Barriers and Facilitators to Delivering Bystander Cardiopulmonary Resuscitation in Deprived Communities, a Systematic Review." This article discusses that there's a higher of cardiac arrest in economically deprived locations. Their data also shows that there is a lower level of individuals who know or can participate in bystander CPR, and this results in lower survival rates, placing these areas at a disadvantage. This article found that even though lower economic areas have fewer individuals that know bystander CPR than those of higher economic areas, they found that the individuals in lower economic areas would be willing to learn bystander CPR and perform it at the same rate as the general population. And focusing on lower economic areas for our project could be beneficial in helping this cause. This article also discusses the barriers and facilitators to engaging with bystander CPR in deprived communities, and knowing this information could be beneficial in impacting our project. And lastly, this last article is titled "Racial and Ethnic Different CPR for Witness Cardiac Arrests." And this article researched whether the incidence of bystander CPR in witness out-of-hospital cardiac arrest at home and in public settings differs according to the race or ethnic group of the person with cardiac arrest. They found that Black and Hispanic individuals were less likely than white individuals to receive bystander CPR at home and in public locations, regardless of the racial or ethnic makeup or income level of the neighborhood where the cardiac arrest occurred. The article also discusses factors to reduce this cost. This article is important to discuss with our high schoolers as it discusses that biases lead to disparities in bystander CPR. Having our high schoolers identify these biases and make it aware that these individuals are less likely to receive bystander CPR, regardless of the location found, will be imperative in our education. Discussing with our population factors to help eliminate disparity can be included in our education. And so next we conducted a needs assessment in order to kind of assess out in the community what type of things could help with our intervention. So we just asked some questions like what is the preferred language, showing that some Spanish translation was actually needed, and just also assessing how much knowledge they had on CPR. So if they've ever heard of it, are they interested in becoming certified? Have they ever received training, and what type of resources there are out in the community? And this kind of allowed us to assess and see what kind of information could be included in our intervention.
Next, I'll be talking about how we carried out our intervention. So our intervention is a presentation and hands-on skills training through USC Pathways. And we're working with this community partner to focus on lower socioeconomic population. And this includes financially, educationally, and ethnically underserved. According to the article, "Barriers and Facilitators to Delivering Bystander Cardiopulmonary Resuscitation in Deprived Communities," there is a higher incidence of cardiac arrest in economically deprived areas, and bystander CPR in those areas is lower. So it is our goal to address this obstacle to better health outcomes in these communities. So to achieve our goal, we'll address several barriers affecting the rate of bystander CPR, such as misinformation on the Good Samaritan law, knowledge of CPR skills, available resources, and language barriers. Many of these barriers were identified through our needs assessment and community survey completed before the intervention. Our presentation will be bilingual in Spanish and English with official CPR YouTube videos. These short videos were developed and tested by the AHA and found to have been effective in increasing bystander CPR initiation, as well as improving the quality of CPR by bystanders. We'll touch upon Good Samaritan law and emphasize the importance of initiating CPR, as every minute lost in initiating CPR results in a 10% decrease in survival rate, according to bystander CPR in out-of-hospital cardiac arrest. Through hands-on training with adult mannequins led by a BLS instructor and proctored by knowledgeable PA students, our participants can feel confident in learning CPR skills. At the end of our presentation, we will also inform them of places where they can find additional resources to further their training, such as HeartSaver and BLS. In addition, we'll be using pre- and post-test assessments to evaluate participant learning and make sure that they're meeting the objectives. Now I'm going to be talking about health literacy, cultural humility, trauma-informed practices, equity and inclusion, and advocacy. Health literacy is a central focus of Healthy People 2030. It is a well-known social determinant of health and an important barrier in populations whose primary language is not English. We incorporate several strategies to assess and ensure health literacy is improved in our target population. We present our education materials in both English and Spanish to ensure that all of our participants are given material in their primary language. We'll also have a co-instructor and additional staff member who speaks Spanish for on-site support. And we'll also be giving out flyers in both Spanish and English. Our presentation is easier to understand with a SMOG score of 4th grade. And we'll be checking our participants' understanding of our material through pre- and post surveys. Our presentation will also allow time for questions to be addressed at the end. The CDC defines cultural humility as the active engagement in an ongoing process of self-reflection, where individuals seek to examine their personal history/background and how these factors impact others. They also suggest avoiding the posture, framing, and language of hierarchy, supremacy, and saviorism. We're invited partners and should emphasize collaborative, mutually beneficial approaches. We aim to be mindful of these different cultures, ethnicities, backgrounds, and age ranges of our participants. Our goal is to be professional and compassionate to read the room and the audience we are working with. Trauma-informed practice is incorporated into our presentation through avoidance of triggering language or anecdotes. CPR occurs in high-stress situations, and some of our participants may have experienced or seen it done in real life. This is a serious topic that we want to address with careful language. In addition, there may be many of our participants who have cardiac problems or have family members with cardiac problems. It's our intention to empower them to action, not be one of the barriers to initiating bystander CPR. Language is also an important component in equity and inclusion considerations. We aim to use inclusive terms like underrepresented and marginalized rather than oppressed and underserved. We'll be using person first rather than identity first language. We'll avoid ageism and ableism and use inclusive language like older adult with person with cardiac problems. We'll also be avoiding microaggressions and violent language in our presentation and conversation. We want to ensure that we create a safe space for everyone to learn together, and will allow time for questions and openly discuss possible fears and concerns.
So this was our pre and post survey assessment. It composed of 5 questions, and they were handed to the participants before and after the intervention. The first question asked, what happens to a person during a heart attack? 75% of participants initially answered correct, and 100% answered correct after. The second question, initially 75% of people answered correct, and after intervention was 100% correct. So you can see with each of the questions, we did have an increase of correct answers. And this gave us a baseline of where our participants' understanding of CPR was. So in the pre-test, we saw that the score for every question was lower compared to post-test scores, which is to be expected. Participants scored an average grade of 55.6% in the pre-test. In the post-test, in the post-test analysis, we were comparing our pre and post-test results from 14 participants, and we saw an overall improvement in the understanding of objectives. Post-test scores improved by 42% to an average grade of 98%. And the statistics did meet our goals of objectives, which is to see an average increase in competency by 30%, with a passing grade of 80%.
And so after our intervention was carried out, we kind of just did an analysis just to see how things went overall. So we had about 14 participants total, including students and parents, and we were able to lead our intervention with Spanish and English interpretation as previously stated. And after presenting the videos, they were able to participate in hands-on training and any questions were answered. And participants were eager to learn more, so further resources were provided as to how they could further their training. So overall, everything was successful, but a few improvements could have been made. So one, we were hoping more participants would have been able to show up, but they were still able. The ones that were able to be there were still eager and enthusiastic to learn. And even though we had pre and post tests that were implemented, we didn't have a way to assess the hands-on training. So a skills rubric could have been implemented in the future. And also the pre and post test surveys could have been adjusted to better align with our objectives. So our original survey consisted of different questions, but were later adjusted to better align with our objectives. So overall, participants were very grateful for the opportunity to learn bystander CPR, and many shared their various experiences and expressed their gratitude to participate in this opportunity. One story that was kind of notable from our experience was I was working with a parent and she was expressing to me how her father actually passed away from cardiac arrest, and she just wished she was able to do something, but at the time she didn't have knowledge regarding like CPR or kind of the things that led to that event. So she was saying that she was very grateful to be able to participate in this opportunity and just wanted to learn more so that she could be able to do something in the future.
Okay, so for our Star Wish, our first star, we had a wonderful community partner, USC Pathways, who allowed us to reach our target audience effectively. Our second star, although we had a smaller turnout than expected, our audience members were enthusiastic and interested in learning. And our wish for our project was that one aspect we can incorporate for future events would be a rubric for skills assessment during hands-on training. This way we can ensure that the audience members receive adequate training covering all aspects of bystander CPR. Our call to action, bystander CPR has a place in our national schools curriculum, evidenced by Japan's implementation of bystander CPR in their school system. They found that hands-on CPR was associated with better outcomes in school students and young adults after out-of-hospital cardiac arrest. In fact, they concluded that there was better resuscitation and outcome parameters with teaching CPR earlier in school-age children starting at age 7 compared to young adults. Since heart disease is the #1 cause of mortality in the US, this can be one of the ways we can effectively lower this rate and help save lives. We can encourage small-scale lobbying in local school districts and then also target the federal national curriculum. Thank you all very much. All done.